Welcome to the University of Pittsburgh's Health and Explainable AI podcast. I'm your host, Jordan Gass-Pooré, a health and science reporter. Join me as we cover advancements being made in health informatics and explainable AI for students, researchers, and healthcare practitioners interested in applications of artificial intelligence and machine learning. This podcast is produced by the University of Pittsburgh's Health and Explainable AI Research Laboratory at the University of Pittsburgh School of Health and Rehabilitation Sciences Department of Health Information Management. Headed by Ahmad Tafti, Pitt's HexAI Lab cultivates extramural collaborations with academic institutions both nationally and internationally through its research, educational contributions, and this podcast series. Hello and welcome back to Pitt HexAI, a podcast series produced by the University of Pittsburgh's Health and Explainable AI Research Laboratory. I'm Jordan Gass-Pooré, your host, and today we're going to speak with Elizabeth R. Skidmore, a professor in the Department of Occupational Therapy at the University of Pittsburgh and Associate Dean for Research at Pitt School of Health and Rehabilitation Sciences. Welcome, Elizabeth. One of the first things that I wanted just to kick off, because folks might not know what exactly rehabilitation sciences is, give us a brief explanation on what that actually means and what you do maybe day to day to give some context with that.
So the rehabilitation sciences is a broad discipline that incorporates actually many health disciplines that are interested in studying how injury and illness occurs and how do people recover from illness and injury, what interventions make an impact on that recovery, and how we can best deploy those interventions within health systems and communities. So it's a very broad field. Within the School of Health and Rehabilitation Sciences here at the University of Pittsburgh, we have over 16 disciplines represented in that broad category of science. And many people think of occupational therapy, physical therapy, speech language pathology as examples, but it also includes our colleagues in health informatics and rehab science and technology and a variety of other disciplines that all work together towards this larger goal.
You focus on neurological rehabilitation, is that correct?
That is correct. My clinical background and my research focuses specifically on how we can deliver interventions to better meet the needs of people who've had changes in their cognition after brain injury or stroke, or there are other conditions that cause that as well. And so we study how we can optimize interventions and reduce disability among those populations. I think you asked me what my day-to-day looks like.
Yeah.
My day-to-day is complex because I wear many hats. So as an occupational therapist in the clinic, you would find me in an inpatient rehab hospital or in the community and at home delivering interventions. As a professor at the University of Pittsburgh, I oversee research in my own lab and then train students and faculty in conducting research. And then as an associate dean for research, my job is to oversee the infrastructure to help all of my colleagues be able to conduct the research that they want to do. And so making sure that we have the right personnel in place, systems in place, and financial management to support their research.
Fantastic. And then I'm just curious as well, because I have a partner whose sister is doing neuroscience for her PhD, and curious about, the kinds of folks or kinds of roles of the folks that you work with. That if you work, do you work with neuroscientists, neurosurgeons, or things like that?
I do. We work in very large multidisciplinary teams. So as an occupational therapist, I work very closely with neuroscientists, neurologists, neurosurgeons, but also physiatrists or rehab doctors, as well as my colleagues in physical therapy, speech language pathology, rehabilitation nursing, psychology. So we straddle maybe the more traditional sciences of neuroscience and physiology with clinical sciences in the disciplines that I mentioned.
I'm also curious too, just to get a little bit more information about you and your background story, about what got you interested in this field.
Yeah, absolutely. So when I was a young girl, I was very interested in health sciences in general, and I really thought I was destined for medical school, and had the opportunity to be part of a number of pre-med training programs. But one of the things that I really wanted to do was to work more closely with people, addressing the problems that they encounter in everyday life and coming up with creative solutions to help them do the things that they need and want to do to be fulfilled and active and productive members of society. And occupational therapy drew my attention to that. And so I was very fortunate at the time you could still train to become an occupational therapist at the baccalaureate level. So I got a bachelor's degree And I practiced for a number of years in inpatient rehabilitation with people with stroke and brain injury, among other conditions. And I had a number of questions about why is it that these people do better and those people don't do as well? And what interventions actually work better? And how can I integrate the evidence better into my practice? And even if I know what the right answer is, what if I'm facing the system level barrier to delivering that intervention? How can I cross those hurdles? That's what drove me back to earn my PhD in rehabilitation sciences and to become a full-time scientist, working closely with clinicians in the clinic.
Fantastic. Throughout your work with neurological rehabilitation, that, because this show does focus on AI, that when did you start seeing or hearing about AI in your field?
I feel like it's been tossed around quite a bit in the last 10 years within our field, but a lot more recently in the last couple of years, certainly with some of the commercial applications coming available and chat GPT and those kinds of things. That's certainly infiltrating a lot of our conversations. But, understanding that most of the people in my field don't have the training to really understand the nuances around artificial intelligence. It's a large word that means a lot of things to a lot of people. And so my personal experience with artificial intelligence really has started to come through my collaborations with Dr. Yanshan Wang and Dr. Liming Zhao here at the University of Pittsburgh when we were looking to try to solve a very real clinical problem within one of our studies. And they were teaching us about the potential value of artificial intelligence or machine learning methodology to help us develop some testable models for assessing how well interventions are delivered in care. I can talk more about that if you like.
I'd love to find out more because I really would like to better understand how, AI is changing your field.
Yeah, so, before I met Yanshan and Liming, I had probably the notion that most people out there that AI is this kind of magic box that you throw information into and then you get an answer on the other side. And much like many of my colleagues, I had a lot of suspicion of that approach because I tend to, as a scientist, think in terms of forming hypotheses and designing experiments and doing confirmatory analyses. And so it felt a little unusual. But the challenge that I had is that I run clinical trials in inpatient rehabilitation. So we've developed an intervention over the last 15 years where we've shown that if we use this intervention, that people with cognitive impairments can engage in their rehab more actively, and they actually end up with significantly less disability 6 and 12 months later than compared to traditional approaches. But one of our sticky wicket issues is to assess the fidelity of that intervention, making sure that what we intend to be delivering in rehab hospitals actually happening. We have to hire expensive therapists who are well-trained to watch about 20% of our videos of care and give us input on, they use a standardized checklist that we've developed to say, yes, this intervention met criteria for fidelity. No, this intervention did not. And that's a very expensive proposition. And I'm getting ready to scale this intervention to about 50 rehab hospitals across the US. That becomes a very untenable solution. And in a kind of tongue-in-cheek way, I was talking with Yanshan and Liming about their work. And I said, well, if you could take AI and look at all of my thousands of hours of videos and tell me whether an intervention session has good fidelity to our protocol or doesn't, is a faithful delivery or not, then that would be great. And they said, oh yeah, that's really easy. And so that's how we went down this path. And I started learning about various different approaches to setting up models, testing those models, and verifying those models to see if we can meet the gold standard of our highly trained raters that are highly expensive and difficult to acquire.
Well, you talked about some of the pros of AI in your field. Are there any cons that you can think of right now for why AI maybe, it would be disruptive in a more negative way, or if there are things to maybe not necessarily calm, but things to look out for while this expands?
I think, the conversations that I have with my colleagues, both my clinical colleagues who are full-time in practice and my scientific colleagues who are, doing like me, checking this out, I think that, there's a lot of concern about using AI with poor assumptions or poor data, right?
Yeah.
And then as a result, getting, faulty conclusions from it, right? And I think AI is no different than any other analytic method that we would use. it's garbage in, garbage out, right? So thinking carefully about how we design our projects, how we design our data, and then what we can and cannot conclude from it, I think is something that's really important. There's certainly a lot of discussion in the national scene right now about the need for transparency with these models, and also the risk of bias, implicit or otherwise, built into these models. So a really important part of my work is looking at health equity and making sure that the data that we use, appropriately represent the breadth of populations that we serve. And we know that our measures sometimes are biased. Providers in their decision making are also biased. EHR data and how we collect electronic health record data can be biased. And so I think there's a lot of concern about, poor use or ineffective use of AI, and making sure that we're very thoughtful about how we design these models and how we test them.
From the student perspective, because you do work with students, thinking about what are you hearing from students around AI in your field? Are students excited or, think that maybe it's a little over?
Excited and overwhelmed, maybe both. Our students like the idea of embracing new technologies and new methodologies. I think they feel overwhelmed. Most of the students I interact with are clinicians or those seeking to be clinicians. They tend to think and make decisions on an N of one, right, based on the client in front of them. And so, I feel that they and their faculty, myself included, are needing more training to really understand what is responsible use of AI and how do I interface with people who have this expertise and have an intelligent conversation to make sure we work towards a common goal. I also think our students aren't very different from the faculty in that some see its potential and some are very concerned about the risks, of bad science. And so I think I hear similar conversations with them.
What kind of training are y'all getting right now?
It's hard for me to speak on behalf of all the rehabilitation disciplines.
Yeah. Or I guess what training you're getting right now.
Yeah, I'll speak to what training am I getting? I'm getting on the job training. I've been partnering with colleagues who have more sophisticated training. And so I've been doing a lot of reading with them. And I would say they're mentoring me in just guided discussions as it relates specifically to our data. But I think within our profession, if I just speak to my one discipline of occupational therapy, I think very little training is being provided in this domain right now. And I'm not sure what will be the future in our discipline. There's the volume of content that our students are having to master relative to our professional standards is a high volume. Thus, we've moved from an entry-level bachelor's degree like me to an entry-level doctorate in many cases. And so I'm not sure yet how that's going to be translated into our accreditation standards and how we're going to train faculty to be able to responsibly deliver that education. At this point, we're in very early conversations within our profession. Speaking to other disciplines, I think that other disciplines in the rehabilitation field, rehabilitation sciences, may be at further along. Some of our colleagues in rehabilitation technology have been using these methodologies for a long time. But I think the clinical disciplines still have a long ways to go.
Well, thank you for that. You had mentioned previously talk about Fidelity, and for someone who is not a scientist, who is a journalist, if you'd be able to help me better understand what that means and sort of unpack the work that you talked about around Fidelity.
Sure. So to do that, I'm going to take a step back a little bit. And so many of the people that I engage with clinically or in my research are people that have recently sustained a stroke. And so most of them had been healthy before that. And as a result of their stroke, they may have paralysis on one side of their body, loss of vision. They may have difficulty producing words or understanding words. They may have changes in their cognition. And when they come into the inpatient rehab unit where they're getting their intensive rehab, there's often a number of goals that we need to address. And they're working with a complex team. There's an occupational therapist, a physical therapist, a speech language pathologist. There are nurses and physicians of various different specialties. And our goal is to get that person to help achieve their goals, but really to return back to the community to continue their rehab. And so, the primary goal is to help them to be able to manage their basic self-care activities and basic mobility activities, getting in and out of the bed, being able to walk a certain household distance and to do so safely so they can return home, continue their rehab from home. in that complex environment, each of those disciplines have an evidence base and a science that guides the decisions that they make in terms of what intervention they provide to meet up with a patient's needs. But as it relates to people with cognitive changes, we're a little more further along in how we address the weakness, motor weakness in arms and legs. But as it relates to changes in cognition, they're a little harder to address. They're a little harder to measure because they're not always observable. You have to kind of see them by proxy, by what goes wrong when someone attempts an activity, right? And they vary greatly among people. And so our intervention has decided, rather than trying to isolate the cognitive problem and treat it, what we do is we work with people to identify what are those meaningful activities you need to do by the time you return home. And let's try those and see where the breakdowns in that performance occur. And then let's use what we call a strategy to address that problem. We teach them a START strategy where they select an activity, they try it, they assess and reflect on a plan, and they try again. So START. And so that intervention is really important, but we pair that with putting the therapist in the role of a guided facilitator rather than a direct skill teacher. So rather than me telling you, once you attempt to tie your shoes and realize you're having trouble with that, or you're attempting to brush your teeth and you're having trouble with that, rather than me telling you this is the strategy you should use, I work with you to uncover a strategy that works well for you using guided cues and prompts. So I'm going to help you figure out what's the method that works best for you, and we allow for that personally centered approach. The intervention is not standardized on the procedures that we use or the methods that we teach. It's standardized on this principle of guided discovery, where the therapist coaches or facilitates rather than telling the client what to do. Okay. And we've done enough research on this over the last 15 years that we know what guided discovery looks like. So we have a standardized checklist where we can look at a video of a therapist delivering that intervention. And we have certain indicators where we see examples of guided discovery and certain indicators where we see a lack of guided discovery. And that checklist allows us to really evaluate whether the intervention is faithful to that guided discovery. That's called Fidelity. Or that intervention is not faithful. It is using a different approach other than the one we intend. Does that make sense?
That makes sense. Yes.
And so when we're testing an intervention, it's not just important to see, does it work? But we need to understand how much of the intervention did they actually get. If I was delivering a pill, you could break down the pill into its chemical components and measure the dose. But when I'm dealing a non-pharmacological intervention where it's verbal and interactive, then I have to be able to break those components down and then evaluate its dose as much as did it happen or not, but how much of it did they get? And so we need that Fidelity checklist when we're getting ready to scale this to multiple hospitals, because if people aren't getting better, we need to understand, is it because the intervention didn't work or is it because they didn't get enough dose of the intervention? Does that make sense?
That makes sense. Yes.
Okay. So like I said, we have this checklist and we have trained raters that we pay a nice hourly wage that watch videos, about 20% of our videos. We don't look at all of them, but about 20% of them. We randomly select them and they apply the checklist and we develop a score from that. And we're looking for 80% or more fidelity. We found that if we have 80% or more fidelity, we can reliably expect a positive outcome for that client. They'll be more independent when they're discharged, and they tend to continue to get more independent over time because they learn skills during rehab that they continue to grow their skills once they leave. But that's expensive and it's time consuming. For a 30-minute treatment session, it takes a trained rater about 45 minutes to 60 minutes to evaluate it because they have to stop and mark and so forth. So you can imagine that's not really tenable when we're talking about moving this large trial or even moving into clinical practice, where we might have tens of thousands of patients receiving this intervention. How will we know if the intervention is delivered faithfully? So I was looking for a way to see if there were patterns in what our trained raters or our gold standards were seeing that could be identified and reliably reproduced with machine learning, with a machine learning approach. And so my colleagues annotated the videos. I worked with our videos, we annotated the videos for them. And then we took the ones that our raters had already evaluated, so we had their scores, and we compared it to what the machine identified and found really high coherence between those two approaches fairly similarly. The long-term application would be that we would be able to have a server where people could upload their videos and get a score on their fidelity as a way of feedback of how faithful their intervention delivery is. Does that make sense?
That makes sense. Yeah. Well, and then in talking about good study design, that to take a step back then to that one, what does it actually mean when we say good study design? What is bad study design?
Yeah, well, bad study design is probably easier to define than good study design. So, when you think about research study design, we start by formulating what the research question is or what the research aim is. And that's what should drive the study design. So in my question, for example, I want to know, does strategy training, the approach we've been developing, lead to less disability over time compared to a traditional rehab approach? And good study design would mean that I've defined each of those variables in that question. I have reliable and faithful measures of each of those variables, and that those variables are as free from bias as possible. They can be objectively measured. No matter who's administering the measure, we should get the same answer. No matter who's being evaluated by the intervention, we should get a similar answer. And then I'm using methodological approaches to analyze those data based on best practices and statistical analysis. If we end up with a large sample that's randomized, we would expect some sort of normal distribution of responses, right, across our dependent variable. But if there's not a normal distribution, we use a different statistical approach because we need to make sure that our analysis methods match up with the type of data we have. So I think that good study design presumes that you have a well-defined question, you have well-defined variables that are measurable with highly reliable measures, and that you are using analytic methods that stay true to the type of data that you have. Bad study design is a flaw in any of those things.
Yeah. So then, I mean, that makes way more sense than too in thinking about the importance of good study design when it comes to anything, I mean, really related to artificial intelligence. And you touched on making sure there is no bias there as well. So just
minimize
about,
as much as possible, right? I think you can never eliminate bias, and a much good study design is designed to try to minimize it. I mean, randomization itself is an idea where, in theory, if I've got a large enough sample and I've randomized appropriately, anything that's unmeasured in both samples should be fairly equally distributed in both samples, right? It accounts for that unmeasured variance. And I think when you think about AI, what's the stuff that we're not measuring that is influencing the model? That's what people are worried about, right? And so if I just throw in 3 variables, but there's probably another unmeasured variable that might be part of what's predicting a pattern, that becomes really problematic.
Well, Elizabeth, too, before we close, we like to ask all of our guests to offer students a research project idea. What's something that you'd love to see students work on?
These ideas seem like big pie in the sky ideas for me, even though when I talk to my colleagues with informatics expertise, they're not as impressed by them. But one of the things that's inherent in rehabilitation, majority of our interventions involve interpersonal interaction and communication. And we have found a way to specify certain elements of that communication with our intervention, looking at whether people are guiding and facilitating versus directing learning, right? But we focused on the verbal aspects of that. So the degree to which using certain words or certain cues or language that invites somebody into the conversation versus tells them what to do. We've not cracked yet is really understanding the nonverbal elements of that communication, which we can pick up through video. And in talking with my colleagues in the computer vision world, right now the state of that science is really focusing on discrete actions as one way of doing that. But most nonverbal behavior doesn't lend itself to an easy taxonomy or classification of nonverbal behavior, right? Which that makes it a little bit more challenging to break down intent and meaning. This is one of the things about human intelligence that's special, right? We all can see nonverbal behavior, and assuming we come from the same cultural perspective, we interpret it similarly without needing a lot of language, verbal language, to help us do so. But we see in our videos, when we're looking at these therapist and patient interactions, there is a lot of nonverbal communication that's communicating meaning in a meaningful way, but figuring that out and seeing how we could use that to strengthen the work that we're doing around how therapy is delivered is something that I think still needs to be done.
Well, thank you for that. And Elizabeth, thank you so much for being on the show. We really appreciate you taking the time. Thanks everyone for tuning in and for following the show. The Health and Explainable AI podcast is produced by the University of Pittsburgh's Health and Explainable AI Research Laboratory at University of Pittsburgh School of Health and Rehabilitation Sciences Department of Health Information Management. I'm Jordan Gass-Pooré. Thanks for listening.